Hi friends, welcome to Charcos. I'm Dr. Seema Balian, the founder and director of Charcos. Charcos is a healthcare recruitment and training company with over 15 years of experience in providing turnkey solution for training and recruitment needs for the nurses, doctors, and AHPs such as radiographers, occupational therapists, ODPs, and many more. OSCE training for all fields of nursing such as adult nursing, mental health nursing, pediatric nurses, midwifery, and learning disabilities. OSCE training is available in India as well as in UK. Orientation for life in UK. OSCE exam bookings and the logistics bookings. Excellent pastoral care. Our state-of-the-art learning platform includes reading materials, videos, quiz to enhance your learning and equip you for a positive and a better outcome. For more information, please visit our website www.charcosglobal.com. Our Facebook page, Instagram, and LinkedIn pages by the name of Charcos Global, and subscribe our YouTube channel. Press the bell icon for regular updates and all the information that you require. We are looking forward to seeing you on our site and being a partner in your enhanced journey. Thank you very much.
Okay, so coming to the complex birth or the breech. Breech is the one which we are going to be discussing as a part of the complex birth. So have you seen or have you been involved in a breech delivery?
Yes, doctor.
Okay, Priscilla, what about you?
Mine was delivered by cesarean section.
Okay, not actually a breech delivery. Breech vaginal delivery.
No.
Have you seen a breech
No,
vaginal
yeah.
delivery? No. Okay.
No.
Okay, that's fine. Yeah, so anyway, nowadays it is less and less of the breech vaginal deliveries that happen. But it is something because of the ultrasound scans and things that they are diagnosed much in advance and hence go for the cesarean section for that one. And that's why you are not seeing many breech vaginal deliveries. But for since you are a midwife, you need to be aware of and you need to know that if at all you come across a breech vaginal delivery, then what all other things that you need to be knowing and how to conduct that one. Okay, so that is what we are going to be discussing in today's scenario or today's topic. So do you know that what exactly is a breech presentation? When we say it is a breech presentation, what do you mean by that?
Doctor, it happens when the baby is presenting at times with the buttocks, the bum, or yeah, at times the bum.
Yeah, so majority of the time it is going to be the buttocks, but then any lower extremities, right? That is something that what we will call as the breech delivery. And breech delivery, the presenting part can be different things, but most of the time it is the buttocks that are going to be. Yeah, so it and as we have already discussed that this is not a typical position, but about 3 to 4% of the full-term pregnancies would be a breech presentation as well. So these are the type of the breech presentation which are there. And as I was saying that it can be different types that how it is presenting. So we can see that there is a frank breech. And in the frank breech, we will say that it is the baby's buttock that aim towards the vagina. Legs are actually folded up and they are sticking straight up as if near the face. So the feet are near the face. So that is called as the frank breech when the presenting part is buttocks. Then there is a complete breech where the baby's buttock, they are downwards, but both of its hips and knees are flexed. So it is as if that the baby is in a sitting with the folded legs. So that kind of a position. Then there is a footling breech when it is the presenting part, or the part that you see first is the one of the baby's feet. It is pointing downward, and that is the one which is going to be delivered before the rest of the body. And then there is a transverse lie as well. That is when the baby is lying horizontal and instead of the vertical sort of thing. And in this way, it is quite possible that the shoulders might be the one which are entering the vagina first. Yeah. So can be quite tricky to deliver this one. So these are the type of breech. So it can be like a frank breech, complete breech, putling breech, or the transverse lie. These are the 4 most common type of the breech presentations.
Hmm?
And then coming to, yeah, you want to ask anything?
Okay. No, please. I'm okay.
Okay,
No, please.
okay, that's fine.
Yeah.
Yeah, so then coming to that, what could be the causes of the breech presentation? Yeah, now, although there are nothing which says that 100% of the time because of this reason the breech is going to be, but there are certain things which put you at a slightly more risk of having a breech presentation. And out of that, they are like that if it is a multi-para, then that is one of the thing, or multiple pregnancies, or pregnancy with multiples actually. So if there are more than one baby, then is also that one of them could be a breech delivery. Then if there is a history of premature delivery, so premature babies can be a breech delivery because it did not actually set in that one. We know that in early pregnancies, the baby keeps on moving, and the presentation can be different. If the uterus is having too much or too little of amniotic fluid, so that can also lead to the breech presentation. Also, if there is an abnormally shaped uterus, so, and that can, because of the fibroids and all that thing, so that can also make it that high risk of the breech presentation. And then if the placenta covers all of the parts of the opening of uterus, such as placenta previa or something, then that can also lead to the breech presentation as well. So these are some of the reasons that, or the causes that why the breech presentation can be there, and or who are at a higher risk of having a breech presentation. So now there are some just common questions about this one to understand the breech presentation a little bit better. How do we diagnose a breech? Yeah, so we know that majority of the time, and nowadays it is because of the ultrasound scan, but also with a physical examination near term, or a PV examination, or even the per abdomen examination as well, you are able to diagnose the breech. Because if you are feeling the head on the top of the abdomen, then you know that the bottom is going to be towards the pelvis, and hence it is a breech delivery. So you are able to diagnose with physical examination, and you can confirm it with the ultrasound scan. Now, can we change the breech presentation to cephalic? Then yes, there are ways that you can try some maneuvers, such as the external cephalic version. So that can be tried between 32 to 37 weeks, but it is not suitable for everyone, and it can have the complication. And it should be done by an extremely experienced obstetrician that who have done it and who are feeling very comfortable. And there needs to be a real solid reason that why you would want to try this one. But if you need to answer the question, then yes, extended version can be tried. Then normal delivery versus cesarean section. In the case of a breech delivery, then most of the time, if it is a diagnosed breech, then you will go for the cesarean section. But in some cases, vaginal delivery can be tried. If it is like, again, a very important reason for trying a vaginal breech delivery, then it can be done. But otherwise, majority of the time, you will go for the cesarean section. So if we are trying for the vaginal breech delivery, then the baby is going to be at full term and frank breech presentation, because that is the one which is the more easier one, when it is the buttocks pointed out and the legs are towards the face of the baby, or the feet are towards the face of the baby. If there is no signs of distress, and we'll need to make sure that the fetal heart rate is monitored closely, The progress of labor is smooth and steady with the cervix being wide and fully dilated. The pelvis should be a good size. No other complication should be there when we are trying for the vaginal breech delivery. The mother should be healthy. The baby should not be too big. The mother's pelvis should not be too narrow, and like everything needs to be aligned in a perfect sort of manner. The anesthetist should be available at handy, and the pediatrician should also be there just in case if we need to go for a cesarean section on a very short notice. So when all these things are there, then there is a case that what we can make to try a vaginal breech delivery. With the risk which are there, like when we are doing a vaginal breech delivery, we need to be aware that there is a possibility that we might have to deliver the head by forceps. There is a possibility that there might be cord prolapse, and there is also a possibility that the fetus can go in distress. So that is the reason that we need to be fully aware, and the anesthetist should be available, and all the emergency, the theaters and everything should be available just in case if we have to do a emergency cesarean section. Any questions so far? Nope. Okay, so we'll continue. Then if you are going to be approaching an undiagnosed breech, then if you are outside of the hospital, when we have delivered or when we recognize that it's a breech, vaginal breech delivery is imminent, then we need to again treat it like an emergency situation only. So we need to call out for help. If you're outside the hospital, then call 999 and make sure that the nearest obstetric unit is aware that there is a breech delivery coming in. You need to make the mother aware of the emergency situation, because it is not a normal cephalic delivery that is going to happen. And you need to gain consent that whatever is required for that, you will need to take certain measures, certain maneuvers and all those things. So you need to be making the mother aware and gain consent to provide the care. Obviously, you will need to continuously check for the maternal and fetal well-being. And you will try to deliver the physiological breech following evidence-based practice of hands-off. Now, when we say hands-off, normally what happens is that, see, if all those things which we discussed, that if the conditions are absolutely in the favor, that the mother is like healthy, the pelvis is good size, it's a frank breech, there is no problem with the labor, there is no fetal distress, and nothing else is happening, then we can just leave the baby to be delivered on its own kind of thing with close monitoring. That is the hands-off technique, because things will happen and they will fall in place, and the delivery will happen with a minimum support from you. But of course, the close monitoring that is going to be required, that as and when and whenever the help is required, that you are there to do that, take over and to help. You will need to monitor the fetal back. It should be anterior in line with the symphysis pubis. So that is there. Then if there is any delay in the birth of the head, so the rest of the body has delivered with a breech, but then the birth of the head is going to be very, very important, and there should not be any delay in the birth of the head. So within 5 minutes of the delivery of the buttocks, or within 3 minutes of the delivery of the umbilicus, the head should be out as well. You will need to assess that for the delivery of the head or before that whether there is any need for the episiotomy. So, and once of course, like you have to make sure that when you are calling out for help, that you are calling out for all those people who you require over there. So who all are the people who you will require? Which mnemonic are you going to use for this one?
Doctor, is it the people you are calling for help?
When you call for help, when you are in the hospital, when you have reached in the hospital, and you say that it is going to be a breech delivery, and you have declared that's an emergency situation, you are going to be calling for help, and you need the multidisciplinary team over there. So who all are the people that you need over there?
So, as we already said, you call for the senior midwife.
Yeah.
You call for the senior obstetrician. You
Yeah.
call for the pediatrician,
Yeah.
the anesthetist, midwives, extra midwives, the
Yeah.
scrub, and yeah, the scrub. And okay, you can also let your colleagues inform the theater about the case.
Absolutely. So these are all of the people. So once you have got help of all these people, then you are going to be trying out some maneuvers as well. Yeah, because there are certain maneuvers when you are delivering the breech, especially like the head when you are delivering, that there are certain maneuvers that you can perform. But you need to make sure that the team is around you, or they are there to sort of support you with any of the actions that you are taking, and any emergency situation that if things are not working out fine. Okay, so now looking at some common maneuvers that what you need to be aware of when it is a vaginal breech delivery. So episiotomy, we know that okay, we can assess that whether there is a need of episiotomy, and we can be on a slightly more of and that uh, sometimes it is better to have an episiotomy rather than just waiting and there might be a tear and all that sort of thing. So it is that is only going to facilitate and make it easy for the delivery to happen. So we know that what the episiotomy is, so I'm not going to go on that one. Then we come to the next maneuver, which is called as the love set maneuver. Now, if you see on over here, these A, B, C sort of thing. So basically, what happens is that you are trying to deliver the baby. And again, like yesterday, what we were saying, that the shoulders are the widest sort of area. And we need to make sure that the shoulders are delivered correctly. And in order to deliver the shoulders, we have to do a certain maneuvers to rotate the trunk of the fetus. Yeah, and that is when we are rotating the trunk of the fetus, there is a certain way that what we will rotate, and that is called as a love set maneuver when we are doing that one. So the first rotation is that we are going to bring the posterior to the this posterior shoulder towards the anterior sort of thing. So we are going to be rotating in such a way that we turn the shoulders to the to bring them up toward the lower shoulder, bring it up towards the symphysis pubis. So, and if you see that while doing that, what happens is that you are actually relieving it out, and the shoulder actually get delivered because you have rotated and brought it out. And the posterior sort of the P, it was down first, and you rotated and it comes up. And when it comes up, it is almost out of the symphysis pubis. So it is almost delivered, that one. And then you are going to
Dr.
rotate it
Sima,
back again. Yeah.
I can't see
You're
the
not able to
screen. No,
understand.
my screen is not changing.
So
I'm
in which is where are
I'm
you
seeing
stuck?
causes of breech presentation.
Mercy, are you able to see my the screen?
Yes, please. I can see it.
So yeah, so I think that I don't know that it might be
Common
Priscilla, it might be because of your
My
yeah, because of
what
your
network.
I'm
internet.
seeing is the common maneuvers of vagina breech
Yeah,
delivery.
yeah, that is what I'm discussing at the moment, and that is what you should be
Oh,
seeing. So Priscilla,
Yes.
you can go out and then join back again, because this is important that you need to see this one.
okay.
Yeah, I think there is some internet issue with Priscilla.
Priscilla, come to Liverpool.
Yeah, she needs to come over there. Yeah, you have good connection. Can you see it now, Priscilla? Hello, Priscilla, can you see my screen now?
Oh, yes. Sorry. Yes,
Oh,
please.
yes, you can see it now. Okay,
I can see
so we were
common
discussing,
maneuvers for vaginal breech. Okay.
yeah, that is what you need to see. So we were discussing about the Lowset maneuver. So if you will see, this is the picture. These are the three ABC things that I want you to be focusing on. Yeah, so and in these ones, you can see that how we rotate the trunk of the baby to make sure that we deliver the shoulders. Yeah, so when we rotate on one side to bring like the posterior shoulder, we are bringing towards the symphysis pubis, making it anterior and hence delivering it. So if we rotate it once to bring the posterior shoulder up, this will actually be coming out because you have rotated in such a way while rotating, you have brought it out. And the posterior shoulder is actually the P1, it is actually now delivered. And then to deliver the other shoulder, the one which says anterior, you rotate it back again. Yeah, and you deliver the anterior shoulder as well. So it is the rotation of the trunk that you need to do in order to deliver the shoulders, which is the Lowset maneuver. So it is the rotation of the trunk of the fetus to facilitate the delivery of the arm and the shoulders. Yeah. Did you kind of understand this one? I know that probably when you will do it, you will
No.
know it better. Okay, what did you not understand?
Everything
Everything.
about the
Okay.
Lowset maneuver. Yeah.
See, what you need to imagine over here is, yeah, that imagine that there is a vessel that is there, a round sort of vessel, and there is something stuck on over there, and you have to take the
Okay.
things out. Yeah. And
Mm.
I'm sure that you would have done in your real life as well. So if you try and pull it out just like that, you are not able to bring it out. So what you do is that you twist it around and then you try and pull it out. And
Okay.
sometimes that works. Yeah. Now the reason being is that when you are twisting it, you are making sure that you are using that force to deliver one part and hence give the um, you give the space to the other part. And that is exactly what the Lowset maneuver is doing. It is trying to deliver the widest part of your the baby, which is the shoulders. So you're not able to just pull them out like that. So what you do is that you twist and then you bring them out. And when you are twisting, one part first comes out, like over here, this part, the shoulder, one shoulder comes out first, and it gives the space to the other shoulder. And then you twist it again, and then the other shoulder also get delivered. So basically, this is what the Lowset maneuver is, that you rotate the trunk to make sure that you are delivering the arms and the shoulders.
Okay.
Yeah. Then
Okay.
now, once we have delivered the arms and the shoulders, now we are left with the head. So we need to deliver the head. And we deliver the head by using the Morrissey's smelly wet maneuver. Imagine like, see, you can imagine like there is a bottle, and on inside the bottle there is something which is stuck, yeah, which is like in a round shape like a head, yeah, and you need to take that head out. So what you do is that you are first going to flex. Now over here in the A, if you will see this one, that you are going to be flexing. So you are going to do a vaginal examination. So you're just going to put one finger down with which you will flex the head down. Yeah. And someone is going to be giving a suprapubic pressure as well on the top. And the other, you are supporting the baby with your other arm. So it is almost like that you are holding the baby like that. And when you are holding it, your middle and your ring finger and your index finger are on the cheek like that of the baby, and the middle finger is on the head. So you are holding the baby like that, so that you are supporting the head, and with the other finger you are flexing the head. And so you are trying to bring the head out just by flexing it like that. And then you are going to be doing the flexion, and then you are going to by extension, so you are almost going to be delivering the baby by after that. Once So you just say, normally when we deliver in the Morrissey smelly bed, so what we do is that I will be sitting when I'm delivering the baby. And in that position, I will just stand up along with that. Remember, I'm holding the baby like that. And I will just stand up, and with me, the baby will also get flexed, and hence the baby will deliver. The head will come out and it get delivered. So this is normally that how you will be delivering. First, twisting the trunk to deliver the shoulders, and then with the Morrissey smelly bed, you are going to be delivering the head of the baby. So it is going to be slightly tricky to understand just by me telling you like that. You will actually will have to do it on the mannequin and see. But then it will become very easy for you to understand that these are the maneuvers that you are doing. But you need to know about these maneuvers, and you need to understand that what is the logic behind them, that when we are doing these things. I'm not going to ask if there is any question, because I'm sure that there will be lots of questions you might have not understood. I don't know that. Mercy, what do you think? That did you understand what I'm trying to tell you?
And I have done it before, but I don't know whether with the when you rest the when you put the baby's body on your arm, and by inserting your 2 fingers in the cheekbone, are you going to deliver in a J shape as we do, or is different here?
No, it is going to be the J shape, because see, when I stand up, so if you say J is like that, yeah. So it is like an inverted kind of a J that it is going to be there. So I'm sitting and holding it. So that is the curve that is there. And when I get up, that is the long stick of the J. So I'm going to be delivering it like that. That is the reason I need to stand up to deliver that one. So I'm holding the baby. And then when I stand up, with me, the baby is going to come up as well.
Okay.
So it is going to be that J shape. You can see over here. So this bit is that when I'm in that lower part of the J. So the J is like that. It is becoming like that. And when I stand up, it is going to, this is the part which is the long arm of the J.
All right.
Okay. So that is basically your breech delivery. So you just need to know about these two maneuvers, the Loveset maneuver and the Morrissey Smellivet maneuver. So now I'm just going to show you, or we'll quickly go through the criteria as well, that what do they say. Delivery. Okay, can you see my screen?
Yeah.
Priscilla, you
Yes,
need to tell me
please.
that if you...
Yes, I can.
Okay, so over here, then if we go through it, so we will have to say that it's a breech delivery, and we'll need to declare that it's an emergency. And if we are outside, then you call 999. And if we are in the hospital, then that's fine. We'll know, still we'll need to call the multidisciplinary team and say that it's an emergency situation. We have already told the woman, we have gained the consent for the care for that woman, for that one. And that it is important that we involve the woman in the care planning and the decision making as well. So we'll need to take the consent and inform the woman properly that what exactly is happening and how you are going to be approaching this one. Yeah, then we obviously before we enter into any of the maneuvers or any of the things, we constantly need to make sure of the maternal and fetal well-being. And if we are outside, then we need to inform the obstetric unit, nearest obstetric unit for the emergency care. Then we are going to show, or when we are going to be delivering, then that is where we need to be delivering by the physiological breech safely. And all the things that what we need to be doing, taking into account. And for the exam purposes, we'll need to say that it needs to be the frank breech, and it is important that the fetal back being the uppermost sort of thing, anterior in the line of the symphysis pubis. So the baby is actually lying like that. So the back is on the top that you can feel. Then you are, if you'll need to make sure that you are able to rotate and you are able to hold the baby, and the back is always going to remain as an anterior position, because that is the position which is the most suitable one for you to rotate and perform the love set maneuver as well, and to deliver the shoulders. So we need to make sure that that position is maintained. We have already discussed that it is important that the head should not be delayed for more than 5 minutes if after the delivery of the buttocks, and after the delivery of the umbilicus, there should not be more than 3 minutes. So we have to make sure that we deliver the head within the first 5 minutes itself of after the delivery of the buttocks. Yeah, and need for episiotomy also we have discussed. Then demonstrate the ability to remove the extended legs. Now this one, have you ever, do you know that how you are going to be removing the extended legs? Now that is also something that probably when you are going to be, when you will see in the mannequin, you will be able to demonstrate. But normally what will happen is that imagine that it is the buttocks that have been delivered and you need to deliver the legs. So, and the legs are extended. So what you normally will do is that by doing the PV examination, you will at the back of the knee, you will press at the back of the knee. And this is exactly what is going to happen. As soon as you press the back of the knee, the ankles are going to turn, the knee will flex, and then you hold it by the ankles and you deliver one leg, and then you do the same thing on the other side and you flex it and hold it and deliver the other legs. Yeah, so because they're extended, you will need to press at the back of the knee on the popliteal fossa in order to flex them, and then you deliver them. Yeah. So you should not just pull them, because otherwise there can be damage to to any of the nerves and things. So this is the most safest way of delivering the legs. Then we'll need to, once the legs are out, then we'll need to perform the love set maneuver by twisting or rotating the trunk twice. So once for one sort of a shoulder, and then again for the other shoulder. So we'll have to take that one out. And for the head, it is going to be the Morrissey Smellivet maneuver that we'll have to do to deliver the baby in a J-shaped manner. Then once we have done that, then you are verbalizing the fetal condition is anticipated. So you have already called the pediatrician. So you are going to hand over the baby to the pediatrician and for the extra support. And over here, you will also need to mention that you are going to be checking for the APGAR score. You are, this should be the APGAR score, and you will need to make sure then you are going to do the skin to skin if the APGAR score is looking fine in the first minute. And then making sure that the placenta and all those things are delivered, and you are doing all your written bit and documentation and all those things. So I think that we have covered all of the points in the presentation. There is nothing different or new in the criterias which are there. But are there any questions that any of you want to ask?
Okay, please. My question is, with the Lover's maneuver, are you going to use towel to cover the baby when the lower extremities are born? Are you going to use towel to cover the baby before you hold the bony pelvic to twist each arm?
It is advisable to use the towel because the baby might be quite slippery. Yeah,
Yes,
because of all that amniotic fluid and things. So it is always a good idea to hold the baby with the towel. so that
And even to
you are
prevent
able to perform.
hypothermia.
Yes, and hypothermia as well. Although, as we said, that within it usually will happen quite quickly, but 5 minutes is also quite a long time for hypothermia as well. So it is always advisable to cover and hold the baby with the towel.
And my other question is, with the APGAR score, are you to verbalize just the score? Oh, let's say I can see my baby is crying. My baby is maybe you form something like what we say. Oh, the baby is crying, so
No, you
maybe
will.
APGAR score,
Yeah,
APGAR score of 10/10. Back home, you
yeah.
say,
You can. What
let
you
me
can
give
say is,
10/10. So I used to
yeah,
verbalize the score, or you have to
yeah.
explain
So
the APGAR score. As yesterday, Priscilla said that you talk about the appearance, the tone, the like those things. You have to say it, or you just say the APGAR score is this.
yeah, so what, rather than saying the Apgar score is this, you will, as soon as the baby is delivered, you will ask the examiner that, examiner, please, can you tell me what is the Apgar score of my baby?
Okay.
And the examiner
Okay.
will say that, okay, it is 10 out of 10. And then you can say that, okay, since the Apgar score is good, I'm going to be putting the baby for the skin to skin to the mother. And now I'll just go on to do the cord clamping and cord cutting and the delivery of the placenta.
Okay.
So these are so you do not need to make up anything as such. Whatever information that you require, you can ask the examiner. The fact that you have asked the examiner about the EPGAR score in itself is going to be giving the confidence to the examiner that you know about the EPGAR score. So you do not need to explain the whole of the EPGAR score until and unless if the examiner asks you that, okay, what do you mean by the EPGAR score? Then you can explain it. But otherwise, you're not, it is not a requirement that you have to say that all of the EPGAR score. I think that what my suggestion would be to go through, please go through the recording again and try and understand the theory behind all these maneuvers and things. Because once you have understood the theory, it will become easier when you are doing it in the practical and when you are trying to explain it as well, because you would have understood that what exactly you are talking about. Yeah. And once you are over here, then we can do the practical side of it as well.